Welcome, good afternoon. My name's Matt Byerly. It's wonderful to see so many young faces here, all future researchers, hopefully. Would you mind raising your hand if you have been involved in anything health related in rural communities to date? A few people. How about rural health research? Couple. Most of those involved in academic research. Again, my name is Matt Byerly. My home is in Wichita. I wear several hats. One is the Associate Dean for Research for our campus, one of three of the KU campuses. I'm also the acting chair of the Department of Psychiatry and Behavioral Sciences. I'm also the medical director of our CTSU. But about 10 years ago, I took a giant leap in my career. You wouldn't get all this background if this wasn't, if I were. But it will help you, I think, have a better understanding of where I'm coming from. So the first 20 years of my career were focused on clinical research in schizophrenia and then translational research in Fragile X syndrome adults and at Southwestern in Dallas. And I especially got a little bit less excited about the more and more focused that the research was I was working on. And I had gotten into mental health because I had a family member, a brother that has schizophrenia. And so I came into the field wanting to make kind of immediate direct impact as a clinician. I entered medical school being sure of two things. I wanted to be a psychiatrist and I never wanted to do any research. And about 7 years after I started medical school, I got my arm twisted to do a research project and really loved the intellectual excitement associated with research. But at that stage of the career I was describing to you, I was feeling as though I personally wanted to have more involvement with interventions that were going to make efforts that were going to make impact soon. And also broadly, public health ones. And at the time, one of my colleagues who consulted for Montana State for a new Center for Mental Health, which goal became to reduce suicide in Montana. Talk about a goal for a research center. And they'd had the highest suicide rate for most of the time in the past now 50 years. So I went there to develop that new center. And in Montana, there are official non-rural centers, but most of the geographic areas certainly rural. And certainly Montana is starved for workforce related to mental health. So I got dumped into mental health in rural settings. And I and a group of colleagues of mine that make up this program in digital mental health now, we've done a few of those things, have been working in rural mental health for the past 10 years and continue to do so. But that's how I got to here today. Thank you so much. I can answer this.
Yes, you should do.
And one of my questions would be like, can I have a video come up? How will I start it? I'll leave the motion.
Yeah, next day, you don't mind it. Yeah, you'll just hit the link or whatever, and it'll go to it. Yeah, it should.
Thank you so much.
Yeah, we'll figure it out.
Okay. One of the things I have done in my career for a period of time also has been very involved with education. And one of the things I did was study physicians learn facts. And not surprisingly, physicians learn facts just like at least undergrads learn facts. And they don't learn facts in this kind of setting. Passive didactic lecture listening format is essentially useless for fact. What these sort of sessions generally are helpful for, I'm not sure mine will be in that way, but they can be helpful for making a case for something, exciting people about something. So my goal today really is to try to excite you about something with a few hopeful examples and give you some hope. But I'm going to start with the discouraging news before we have the hopeful example. So the discouraging news, I described it to you in my intro that I began involvement with rural mental health research, service, attempts to make impact about 10 years ago. And at that time, suicide rates were double that in rural settings compared to urban settings. There were higher rates of depression and anxiety, and a whole bunch of reasons for that. Considerable amounts of it understood. I think some of it's still not fully understood. So the discouraging starting point for me today is we've made no impact, we've made no gains in that in 10 years. Still double the suicide rate. And the suicide rate's gone up during those 10 years across our nation and rurally. So when I was thinking about today, one of the ways one could cover this topic is give you, and I have a slide like that, and it has the, yeah. I hear
that. Okay, all right, okay.
Thank you. One of the ways you could do that is list the evidence for available things you could do for mental health in communities for suicide prevention and depression and anxiety. But that would be like a bunch of facts, and these sessions aren't any good for facts. So I'm not going to do that. I'm trying to make a case for some things and have you be thinking about ways we can maybe 10 years from now be in a different place for rural mental health than we are now, which is no better off than we were 10 years ago again. But these fast facts, just to have us think about why was I asked to present on this topic. A little bit about mental illness. Half of people with mental illness have only half have received treatment in the prior year of any time you measure. So half of people with mental illness are going untreated. Not half of people with cancer, not half of people with hypertension, not half of people with diabetes. Half of people with mental illness are untreated in a given year. This one really fits what I just said about first diabetes, first cancer, 11-year separation between symptom onset and diagnosis. Those are cultural factors, stigma factors that enter in there. They affect young people. Most of our illnesses you get later in life. This takes away quality of years. Mental illness takes away more quality of years and functioning than all the disorders. Major depressive disorder is the #1 cause of disability worldwide. Depression alone is the #1 cause of disability worldwide. That's days lost work. And it affects people young. Half of people have mental illness by 14, they're going to get it 75% by age 24. For schizophrenia, most of the people will have it by average for men is 26, 21 for women. They get early dementia, essentially, which is another way to describe it in young adulthood. And it's the second leading cause of death in young people that actually goes all the way up to age 34 for second leading cause. Okay, terrible problem. We haven't been making any headway. And in rural settings, it's even worse. So this may be very unpopular, but I did a Google AI search. So this is my reference for this. being immersed in this literature, I can tell you, Google AI did a fantastic job with this search. So I placed in rural health challenges, ranked mental health, and mental health is essentially always at the top of the list. When you survey rural community residents, they say mental health is our biggest challenge. Johnson County had a super extensive rigorous evaluation recently. And for an actual illness domain that they were talking about, number one was mental health for challenges. This is repeated constantly in rural areas. And these are the reasons. Shortages of providers, geographic regions, stigma, limited insurance coverage. People in rural regions are even less likely to have insurance, and cultural factors. And addressing this is probably our way forward. And the next two slides make a bit of a case that this is my view, that why we have to invest in workforce initiatives. They're absolutely critical. I don't think they're gonna put us any place different 10 years from now than we are now. We've been doing these. For individual states that don't invest in them, they'll do worse than the states that do invest in workforce initiatives. But my case is that you have to do these to keep up with your rural region states. I was just pecking around on the internet for other rural health-based initiatives in nearby states. So this took me about 10 minutes. Nebraska has one, Iowa has two, Oklahoma has one. Everyone has these. And we're all competing for the same pool of graduates or physicians. So again, my point is, I don't think this is a way to advance things unless you invest a bunch more in the workforce initiative than other, at least nearby states. And I'll share just a little bit about how expensive these are in a bit to give you a sense of that. So thinking about these barriers again, you just saw this slide a bit ago. And I'll start talking now about suicide prevention in rural settings and some of my experience with that and some really fantastic work that one of our program and digital mental health faculty is doing. So I'm going to start with the most important suicide prevention study ever done. I'm sorry, I should have the reference for it. It will be on the next slide, but it's published in the Lancet by Wasserman. And this is the largest suicide prevention study ever done that had a positive outcome of any type. There's one larger study, just as rigorously done, for people with presenting recurrently to ERs with suicidality, but the interventions proposed there didn't beat control. That was also published in JAMA. But this one, Youth Aware Mental Health, or YAM, did beat control. And I'll talk to you about, this is one that Janet Lindau of our KU Program of Mental Health has been investing in. We invested very heavily in Youth Aware Mental Health. And when we're at Montana, we became this was published in Lancet. This intervention was developed in Europe, and it's 5 total hours with students in high schools. The facilitators that do it can't be school employees. It's a major challenge to the intervention. You have to find them, hire them, train them, keep them, replace them when they turn over. But this study compared about 2,000 patients per group. You have to do that when the event rate isn't super frequent. Here it was suicide attempts and then cases of suicidal thoughts, but back to suicide attempts. And these bars are showing how much reduction in suicide attempt rates at 1 year if people were in the YAM group versus professional screening. This is the most common used intervention in the US. This became the second large randomized trial showing it doesn't work. It's the #1 used suicide prevention in the US. There are 2 for 2 large RCTs proving it doesn't work. It's still the #1 used one in the US. Maybe that has something to do with why we're not any further ahead 10 years later. So this was the leader, and we worked with the Europeans, Danuta Wasserman, to do the cultural adaptation in the US and to do one very large uncontrolled trial with thousands of students delivered to, and one rural test. But a little bit about this one, this is screening. This is screening for symptoms and risk behaviors. And then once a student screens positive, they're referred to care in some way. And this has never been published, but we've published on it and referenced it as personal communication from Dr. Wasserman, that only about 1 out of 4 of their students that screen positive got any linking at all. And if you could have more linking to care, you might get greater impact. That was the thought. And that's what Janet Lindau has been doing for quite a while. Here's QPR doing nothing for suicidal thoughts. We're not so convinced that it changes attempts, even in a Tennessee, if it's not changing thoughts, but it was not significant for attempts or thoughts for QPR. And there's, yeah. So after the study, YAM was the leader. We delivered it for 3 years while I was in Montana. And my colleague that did it we did it in a 2-state study. It's still going in Texas and has now been delivered to almost 53,000 students. But to do that, it's taken millions of dollars of a philanthropic donation to allow that to continue to happen in Texas. Millions, so it's going one place, one state is in Texas currently for YAM, the most proven suicide prevention known to mankind. One state in the US currently. So Janet Lindau picked on professional screening. Oh, this is just to remind me that we did test YAM with extension agents being the facilitators in rural communities, in 10 rural communities. And it worked just like it did in the urban communities, where it helped all these known suicide risk factors. It works. Worked in the giant RCT, clear indicators from an uncontrolled trial that it probably works in the US, but feasibility is a challenge for some of the reasons I mentioned. Here's Dr. Lindau's nonprofit. She's also an associate professor of our department in Wichita. There's Dr. Lindau. She's a MIT doctorate, and then was a Yale faculty member when she approached me in Montana and said, can I become a mental health researcher? That's been now a 10-year process with her. And she developed this nonprofit with these goals. Reduce suicide by building school-based mental health. Building a school-based mental health system in rural America that includes universal mental health screening and robust mental health services. Holy smokes, talk about being ambitious. So the screening part is built on this evidence. Remember, the professional screening looked second best in that largest of all studies I mentioned to you, plus the U.S. Preventive Services Task Force, which is I would say is widely accepted as the most authoritative group on judging and making recommendations on preventive interventions. And for instance, all of their recommendations are published in JAMA as like key articles. And officially, depression screening and anxiety screening are recommended by this task force. And so strong support to do that. This is what Janet does. She screens 6th through 12th graders in rural settings. And for those students who screen positive, she provides them care at school, it identifies them, connects them at school, and then she provides this thing that doesn't exist currently to a large extent in rural settings. She fills in the mental health services. So a little bit about how she did. This is just to say a lot's done in preparing the school for this type of screening, including having a team of clinicians ready to evaluate every positive screening, urgent positive screening youth. That's one with recent suicidality. They also provide case management for the youth who screen positive. And they provide, as I mentioned, specialist psychiatric care as bridge care. It includes diagnostic evaluation, treatment, handoffs to PCPs. This largely does not exist currently in rural settings in the US. This is what she's finding in the schools, that 13% of students have had lifetime suicidality. That's not at all high. Have any of you ever heard of the Youth Risk Behavior Survey? Yeah, some of you know, it's a every other year national survey of the mental health of youth and some other risk behaviors. And it consistently finds that about 1 out of 10 youth have had a suicide attempt in the past year. 1 out of 10. These numbers are not high. And Janet's finding that 7% of them have had, oh gosh, that was not the right thing to push. Okay, have had recent suicidality. These are the ones that need intervening that day. And this is, I'll have to pick up speed here in a bit. So this is my break your heart slide. This is the proportion of youth who are having recent suicidality. It's like the last 2 weeks by grade. 6th graders, 12%. It's less so as you get out to 12th grade, but so we need to be intervening early, right? Does that surprise you that 6th graders is that high? Does me. YRBS data has exactly this relationship as well. Janet has found that 7% of the students have clinically meaningful depression. This is at least moderate symptoms and at least moderate anxiety. And now for some outcomes. Essentially, every single student that's high risk of that 7% with recent suicidality is evaluated the same day. All of everything, so it's 25% linkage in the Saley study, that big study for professional screening. Here it's 100%. So you can't participate unless you're set up to get linked on that day. Now, these are outcomes data. This is uncontrolled before versus after. And I think while this is very hopeful, this reduction in suicidality, which is measuring about 3 months before the initial screen and 3 months before the follow-up screen and eliminating people that had past suicidality. So that's called incident suicidality, recent, new for the first time. But this data I really want to see in controlled trial data to be fully comfortable with it. This data I'm more comfortable with because I've seen lots of data showing that when you follow depression and anxiety in youth in high schools, their ratings get gradually worse all throughout high school. So to have depression and anxiety go down at all, there's multiple mental health interventions tested in schools for depression and anxiety, and they don't change. They just stay flat or go up a little bit. For the population as a whole, kids that have no depressive symptoms at all, plus the kids that do, there's a 14% reduction in symptom ratings for depression and anxiety. And for the kids that had clinically significant depression and anxiety, these are the percent decrease in their symptoms. Really clinically significant changes. And that impact and that Janet's having with that is been recognized nationally. So this is a national leading approach for this. Okay. Thinking about our barriers, how does screening linked to care stand up for that? Fantastic for geographic barriers. They literally go to the school. It's great for stigma because all the kids do the screening. And they're doing it on a computerized tablet, so no one knows what they're punching and clicking. The limited insurance is there's costs still to doing it. The cultural factors, I think, aren't existing on the first day linkage because all the kids are being seen. There aren't barriers preventing them from being seen, but long-term follow-up, Janet says, yes, there are still barriers there. So that's plus minus for later follow-up. And While Janet has this amazing team of clinicians she's created, she's having to steal them from somewhere else to get them. But she's doing it in a very efficient way where she develops a plan by an expert, implements the plan, and then follow up with a primary care physician. So it's a brief investment in getting proper treatment set up. Here's another potential approach one could have for trying to bring effective interventions to rural settings. And this is a study we currently have ongoing where we're trying to implement a digital substance use disorder treatment that also has required clinician monitoring. Those two pieces. Dr. Ellison, KU Population Health, and Shauna Wright, also of KU are collaborators on this. This is Dr. Ellison's lab, KU's implementation impact research. We're working with 3 mental health centers, and Emily Moore will show you some of her data. And to save us time, I'm going to go through these very quickly. These slides are summarized as Dr. Morrow would say. So these were clients of the community mental health centers who actually have either had or currently have substance use disorders, or being described and seeing demonstrations of the program in pieces and giving their impression of what they would think about using it. And you almost can't describe their excitement for it enough. They're thrilled about it. I have some discouraging news in just a bit. It's not an oversell. The clients love it. They love that it's private. Substance use disorder treatment and going to get that in a rural community is like the highest stigma you can have. When we approach primary care physicians about this exact intervention, can we build substance use disorder screening into your rural PCP clinics and offer this intervention for your clients? They universally said, nope, we don't want to do it. We won't even screen for substance use disorders in our clinic. We won't ask. Super high stigma. Clients love it. They love that also not only that it's private, but they can access it whenever they want. And they said, often I get treatment for substance use disorder after I've had a relapse, but this I could use when I'm having triggers. And I can go use it whenever I want. They love the idea of it. They also said they don't think they'll have any meaningful barriers for accessing the technology. There's a smartphone. The hang up is the clinicians. The clinicians aren't as excited about it. They talk super excited about it, but the actions and follow through for linking and making it happen make it obvious that they're a barrier to it. Okay. There's a reason why I walk you through these particular examples. So when you have to have clinicians also involved, you obviously have troubles with provider availability. You also have the stigma thing I mentioned because you have to interact with a clinician about it. This one does get around the geographic barrier because it's digital, you can do everything, but you have to have calls with the clinician in the clinic. Someone still has to pay for it and it's still fairly expensive. And culturally it fits people with substance use disorders, but it's not been developed for rural. So how about a digital standalone therapy? You don't ever interact with a human at all. Zero. This has been our guide for our entire program in digital mental health. John Grice, Professor Emeritus at University of Wisconsin. He's also a faculty member at our proud KU. Dr. Mintz is in our audience. He's our dean, so he's a faculty member of Dr. Mintz. So Dr. Grice has been the pioneer of, you could arguably say, all of digital health. It so happens that his career was focused on mental health. So clearly the pioneer of digital mental health. He first published on this study in 1990, showing that computer-delivered cognitive behavioral therapy, entirely unassisted, this is lower is better, fewer symptoms, was the best, it tended to be a little better than therapists, but it clobbered control. So since 1990, and then there's a whole bunch of follow-up studies. Here's a whole bunch of them. Remember I showed you, I could give you one of those graphs showing, this is one of those, sorry, painful graphs. But what this is showing is that digital mental health interventions work when they're designed properly. They work. And here's an effect size that I might bring you back to. That's a medium size magnitude of effect. And these are a mix of some standalones and mostly an intervention plus a therapist interacting with the patient. Those tend to produce more. But if you could get that size effect with 100% standalone, then you probably have a bunch. One of the things I would mention is, so this is a way you can compare all interventions for how much impact they have clinically. Antidepressant medications have about half of this impact for depression. So these therapies not only work as well as medicines, they're working better than medicines for magnitude of impact. They work, they have large effect, at least when you have a clinician especially helping. This is a study we did in Montana, and essentially anyone could get in who had at least mild depression. Age 18, Montana resident, internet access, and mild depressive symptoms. So you did not have to have a particular diagnosis. We could have had a self-administered diagnostic tool. We didn't. So these could be people with alcoholism causing depressive symptoms, depressive symptoms associated with schizophrenia. It could be, and probably was mostly people with major depressive disorder with depressive symptoms, but it could be any of those. And these are the impacts. So this is considered a large randomized controlled trial, the sort of stuff that's considered the gold standard of scientific evidence. And higher is better here. This is % improvement in symptoms compared to the start of the study for this standalone digital intervention called Thrive versus control for depression symptoms, anxiety symptoms, functioning. By 8 weeks, you're functioning better than you were for work and social functioning. And you have better mental health resilience. And this, I won't walk you through, sorry, too complicated. This is a follow-up study showing those benefits are present a year later. That magnitude of effect for depressive symptoms is now at that very similar figure of that 0.67. So this intervention has the largest effect size of any of the standalone interventions for depression. And now the best part. Hopefully. So this is John Bryce. You saw that picture before, right? And now that you have a bit of an experience of what's Thrive like if you're using it. Hopefully we have volume.
You've just completed the mood scale, which provides a depression severity score. We use the mood scale in Thrive because depression can seriously reduce the quality of one's life, and because the techniques in Thrive have been shown to help with depression. Scores for the mood scale go from a low of 0, meaning no depression at all, to a high of 27, the most severe depression. Your scores are shown in the chart on this page. Others who scored the way you did today experienced moderate depression symptoms. I'm sorry to hear you're having symptoms that are consistent with depression, but it's good that they don't appear to be too severe. Many people feel the way you do at some point in their lives, and many of these people can, and do, get back to feeling good again. So it's great to see that you're taking action. Thrive will help track your score as you work through the program. Remember that depression usually takes time to improve. A reasonable initial goal is to see a good response toward a score of less than 10 by 4 weeks after starting to use Thrive. The overall goal is to get you back to normal with a score of 5 or less by 8 weeks from the time you started Thrive. That might seem difficult or out of reach, but if you commit to Thrive and to yourself, you may be able to see those kinds of gains. Now that you know what your starting point is, let's decide where you want to go. Thrive has 3 main parts called modules. Each module teaches a different set of CBT skills. Different modules are better for different people. The questionnaire on the following page will help you decide which module is right for you. Click Next to continue.
So what's happened before that video is you've done a rating of how severe your depression is. And you get this introduction, and I wish I could have, I'll just have people who have ever met a mental health professional or ever received care from a mental health professional or know them. Think about how engaging, empathic he seems maybe compared to some mental health professionals. I would say he's towards the top. I know a lot of mental health professionals. That's a very engaging interaction, I would argue. The reason we think that Thrive has outperformed the others for impact is just that people do more sessions with it. We think that's because it's more engaging. So it was the prior versions, many of them, most of them have been static, like cartoons and text. And you'll see that this is a very different experience. It's 325 videos that are algorithmically guided to a person. So this is people with moderate depressive symptoms who are now going to go and do a little test that will allow the algorithm to guide them towards where to start.
You've just completed the mood scale, which provides.
And so I want to give you a sense of some of the other types of experiences and then a rural adaptation that we did specifically to the program. Here's another type of
Of course, there are all kinds of thoughts, but right now we're going to focus on negative thoughts. In Thrive, we define a negative thought as one that depresses your mood and is unrealistic. When we say that a negative thought is unrealistic, we mean that negative thoughts aren't completely based on solid evidence. We might zero in on bad news while ignoring good news. We might believe that if something bad happens today, then that's the way it will always happen. There are a number of ways our brains, which are usually logical, can misinterpret reality. Even people who are the very best at what they do can have unrealistic thoughts about themselves. Abraham Lincoln, before becoming president, thought he was a bad lawyer and worried that he wouldn't make a positive change in the world. Lincoln, who suffered from depression, said he was the most miserable man living. Marilyn Monroe, Jim Carrey, Serena Williams, Sheryl Crow, Russell Brand, Drew Barrymore, Theodore.
You see the magic of CBT. It's not just you, it's a thing now. It's a thing you can get. It's an illness. Abraham Lincoln had it, these other people had it. There's lots of things happening with this beyond her educating you how you'll be doing CBT.
Roosevelt and Winston Churchill all struggled with depression. That suggests that no matter how talented or successful you are, unreasonable thoughts can become a part of your personal belief system. Let me make an important point before we continue. We want to recognize that unfortunate and serious.
I'll stop there. She's going to say if you've had loss of a loved one, that's not what this is for, and so forth. So some education there. Okay. So one of the things that I can't walk you through with enough time is I bet you're wondering, well, what do you do? How do I know what to do? How do I identify my illogical thinking? It literally gives you examples of things that you might be doing. And when you're looking at them, you're like, yeah, I do that one. I'm doing that one. I'm not thinking of any of the positives that I also have in my life. I'm doing that one. So it walks you through step by step how to identify all these things. There's essentially zero challenge in you having to figure out CBT for yourself, cognitive behavior therapy for yourself. It walks you through it in a super effective step-by-step way, which you're not getting exposed to. So I wanted to make sure that you had an understanding of that. Then in addition, while it's walking you through that, it gives you an experience at the same stage you're at of someone else who's actually going through real life cognitive behavior therapy that's relating to exactly the step you're trying to work on.
Of course, there are all kinds of thoughts, but right now we're going to focus on negative thoughts.
Not yet.
Since the spot, challenge, swap process can be hard to envision for many people, it can be helpful to see it in action. The following scenario is based on a true story.
Hi, I'm Kristen.
So you've had teaching on spot, swap, but now you get to see a full example of it.
I think my stats are pretty normal for a woman of my generation. I'm almost 30. I have an okay job that's somewhat related to what I really want to do. I don't have kids yet, but I do have a boyfriend. His name is Brian. We're getting more serious, and he says I love you better than Shakespeare, but he still hasn't put a ring on it yet. Anyhow, I've been struggling with depression on and off for pretty much most of my life, probably since before I even knew what the word meant. I think because of this, I've gotten pretty good at hiding my feelings from friends and coworkers. I put up a really good front, so to everyone else it looks like I've got it all figured out. I seem all happy and confident, but things can often be completely different on the inside, and the amount of energy that it takes to pretend that I'm okay, it's really hard to keep that up. I think that's why I started working with a therapist a couple months ago. With her help, I was able to see how the way I was feeling was connected to the way I was thinking. So I had negative thoughts, they made me feel bad, I believed more negative things about myself, and then felt even worse. I wasn't sure which came first, the problems with my thoughts or the problems with my mood. And I still don't know, but in a way it doesn't matter. I just needed to break the cycle somehow. So after talking with my therapist, we decided that the first thing I had to do was to be really clear with myself about the negative thoughts I was having. At first this was pretty difficult, both because it was kind of painful for me to be so honest with myself about some of these thoughts, and also because I'd believed them for so long that I was barely even aware of them. Sort of like how I've gotten so used to the ugly tile in my bathroom that I don't even notice it anymore. But when I really focused, I started to see plenty of thoughts that were probably affecting my mood. A lot of them centered on my future with my boyfriend, mainly having to do with whether our relationship is progressing at the right pace and whether we'll ever get married and start a family, 'cause that's really important to me. I was bothered by questions about whether I'm doing the right thing with my life, like, am I making a difference in the world? Sometimes I don't really feel like I totally fit with my job, so I got down on myself about making bad career decisions. I even worried about whether I'm exercising enough. I felt like I was always just around the corner from gaining a lot of weight. And for a long time, whenever I had these thoughts, I couldn't do anything but feel down. But my therapist helped me to learn to ask whether my negative thoughts were actually reasonable. I began to realize that my negative thoughts had a tendency to be unrealistic. Things are going well with Brian. I generally behave like a good person and make other people happy. I've been given more responsibility at work. I go to the gym or walk at least 3 times a week. In fact, my dress size hasn't changed in 5 years. Realizing that some of my negative thoughts weren't totally accurate really freed me up to look at each situation in a new light. For instance, I didn't have to get as bogged down by thoughts about my relationship with Brian because I was developing a more realistic way of seeing things. It's taken some work. Like, whenever I had gloomy thoughts about my relationship with Brian, I'd have to push myself to try to switch tracks to what my therapist calls constructive thought. But each time I did that, it felt a little smoother and more natural. It's still in the early days, but I do think the system's working, and I feel like it's helping me become healthier and get to where I want to be.
We hope this example helped you understand how constructive thinking works. But if you're not feeling
One more video for you. So that's for, remember, there's different modules for people that are having more difficulty of particular types leading to depression. That's for people having trouble with unrealistically negative thoughts. The two other major interventions are assertive communication and behavioral activation / rewarding activities. Those are the same thing. And everything you've seen there, we viewed as non-rural. So when we did an adaptation for this, I'll show you an example of a rural adaptation video we did that was for the rewarding activities behavioral activation module.
Since the SPOT challenge
These are the two longest videos of the entire program.
To show you a real-world example of how rewarding activities can work, we created this video about someone we'll call Jason. This video is...
I don't know if I had a sense of this. Raise your hand if you had any time you've lived in a rural setting. Okay. And so I think you'll see pretty big cultural differences between these two. And I'm very interested to hear what the people who grew up in a rural place think of this and the urban.
based on a true story, although we have changed his name and some of the details to protect his identity.
Hi, my name is Jason. I'm 32 years old. I'm a Marine veteran. I'd like to tell you how rewarding activities have helped change my health and my life. I like to consider myself an old school entrepreneur, but most people would call me a rancher. About 6 years ago, my wife and I bought some decent land, and we leased the neighboring pasture and started a small grass finishing cattle operation. We have about 150 head of Angus, and we raise pheasants and grow seed potatoes on the side. We've had our ups and downs, some bad luck here, some falling market prices there. And to make ends meet, I carved out a small pheasant hunt operation, and it helps in the fall, but I have to say it's not easy. And I think over time, the strain on my family started wearing me down. You hear about guys going through a crisis buying a new pickup truck. For me, I just ran out of energy. Everything felt like a chore, even the things I used to enjoy. I was tired all the time. My wife and I thought something was wrong. So I went to the doctors, had some tests ran. Of course, they came back all clear. So the doctor started talking about stress and depression, and I just told him that he was crazy. Just because life is hard doesn't mean that you're depressed. So I went home, and hoping it would all pass. Well, it didn't. It got so I was barely making it through the day. I was collapsing in a heap in the evenings, and I started getting these strange muscle aches, joint pains. I couldn't sleep at all. What amazes me to this day is that it felt entirely physical and not psychological at all. I just chalked it up to the years I spent in the Marines getting knocked around, and I was set to forget it until my wife finally put her foot down and sent me back to the doctor. More tests. They all came back clear too. He sat me down for a serious talk. He'd been my doctor for as long as I can remember, and he said that I changed. I wasn't much like the old Jason that he knew. He said he used to see me at the town events, competing in the local rodeos with my friends. He said that I always had a story or two to tell him about fly fishing and hunting. All seemed to have dried up, and I seemed different to him. I just tried to make excuses. That's just what happens when you grow up. He was having none of it. He asked me, when was the last time I just went and did something that I like to do? I thought about it. Couldn't remember. That was a real eye-opener for me. He sent me home with a lot to think about and some homework to do. That week, I had to mark down every time I did what he called a rewarding activity, and at the end of the week, the calendar was still blank. I'd never considered myself a procrastinator, but I guess I've become a pretty good one. My doc explained that usually the first thing people drop when they're down is something they enjoy. and that makes it worse. He told me it's really important to do something rewarding, enjoyable, or both every day. Nobody understands why it works, but it does. It also improves mood and sleep, too. He told me to get out there every day and do something enjoyable, even if I didn't want to. He said to do it anyways and your mood would follow. So I decided to start simple by getting back into fishing and hunting. I'm a work first, play second kind of guy. But I found out that if I waited till the end of the day to do all the fun stuff, I'd be too tired. So I decided to plan for the morning. I'd wake up, do the chores I absolutely had to do first thing, and then midday, take a break. Just cast a line in our pond for a while, or head out into the field and scare up a pheasant or two. I only made it twice that first week, but it gradually became a habit, and it became a new way to tackle my days. My sleep improved, and I felt more energetic. A month or two went by, and I found myself getting my good horse back in the ring and practicing my roping. A little while ago, I realized I was starting to feel like my old self again. Sure, I still had things to worry about, but they didn't seem so bad. I started inviting my buddies to walk up pheasants and go fishing, and just last week, I dropped in on my rodeo team. I was weary at first, but they were just happy to see me. My wife has seen the change. Now, if she catches me working at a certain time in the morning, she comes out and practically pushes me to saddle up my horse or go get my fishing rod. If you're down and thinking about making a change, my advice, just get on the horse. Start taking time for yourself every day. Start slow, but good luck to you.
As you move forward in rewarding activities, you might find
That's meant to be relatable and also give them some more clarity on the exact things that they're working on. Again, you're not seeing these steps that guide them, the homework and so forth. But a digital standalone, if we think about the barriers for rural mental health, it does really well now that we don't have any clinician involved. There's no providers, zero. Works at least as well, larger effect size than antidepressants, with no provider, no geographic barriers. Wonderful answer for stigma. No one ever has to know you do it. Limited insurance coverage. That's like, the question there is who's paying for it? That's a challenge. It's something our group's particularly working on, trying to actually make Thrive available at very, very low or no cost to people. The goal we have. Cultural factors depends on how well we're getting the cultural adaptations. And I just have, this is our last slide. This is a ranking that our KU Rural Health Council Committee on Mental Health and Behavioral Health, of which it's more than 9, but these are the 9 surveys we got of a whole bunch of possible interventions we could do in rural settings. And these were the top 5 that emerged. And here, 1 is your best score. That's a perfect score, 1. And you could go up to 5. And the digital standalone was most recommended. Here's an ambitious workforce initiative is here. Still, these are all in the positive range. We probably should try to do all of these. If we think about costs, there is a major state-funded behavioral health workforce initiative in Kansas right now that's focused on the Wichita area. That's $5 million in its first year. And the budget is potentially $7 million next year. So some sense of like costs and things. I think that's good. So we have just a couple of minutes. Thoughts, impressions, questions? Yes.
How are people getting access to this? Do they have to get it from their primary care and like screening that's done there, or?
For the digitals?
Yeah.
So currently, digitals that have evidence of working, the only available route through them currently in the US is through a provider who writes you a prescription. And so they have extremely limited access. Thrive is in the Kaiser system nationally. It's also in the Henry Ford Air system. We're hoping to have it become available in Kansas and then nationally directly to consumers. Well, I did have, I'm gonna make an additional point that there are hundreds of mental health related apps. Almost none of them have ever been tested, let alone in a randomized controlled trial. You get down to like 10 to 12 total randomized controlled trials related to this field. Yes.
My question is just a follow-up. So, and you mentioned it a little bit about cost. So can you tell me, so if somebody is able to get a prescription, what does it look like to access from a cost perspective?
So the best example I can give you of the ones that I shared with you was the substance use disorder one. If your prescriber prescribes it, you can access it for $100. That's for the substance use disorder one. And I didn't mention, it has 7 positive randomized controlled trials for the substance use disorder ones. It works, highly proven. It's the most proven in that particular one. So $100 for that. But for substance use disorders and all the FDA approved ones currently, they're priced at about $1,200 per use. That's where we're especially interested in trying to get the leader in depression, the most common, most disabling disorder, Thrive, made available at little or no cost.
Are the videos only in English?
Yeah, so those are all the things, right, that the part on the end about, are we addressing cultural issues and so forth? So Thrive is only in English currently. It has, the original version I would describe as having a very urban feel, right? There's this telescope behind her, sitting there in her urban living room. And it has a rural adaptation, but it doesn't have a Latino adaptation, a Native American adaptation, American adaptation. It doesn't have any of those. And that's our hope and plans actually for Thrive as well. Yes.
Were the digital versus in-person treatments tested in a stratified manner? Was it an entire population that it was positively correlated for? Did they look at it from different races and socioeconomic, educational standpoints? And did any groups stand out as more effective or less effective?
So I don't have several thoughts about that. We don't have any answers about outcomes. Are there differences in racial responses? There are differences in men and women who participate in mental health treatments, especially depression and anxiety of all types, including in Thrive. 2/3 of the participants were women. Every depression trial ever, that's the number. More women than men. More women are affected than men. There's not a need to stratify in a randomized controlled trial because it's going to give you equal numbers or control for that of whatever types, as long as you have enough of the people of particular, for instance, race types. So, but that is a very serious shortcoming to Thrive RCT, which was like 98% white. It was a rural Montana, that's Montana's population. But yeah, so coming back here, we need tests in those settings. There's a question about, do these work as well as men as they do in women? We know they work in women because most of the data is from women. Thank you very much for your time.
It's a little break now, so check the agenda, but then I think we're going to the forum hall already, so. Very low. Yeah.